Great. Well, thank you for the invitation. I'm sorry I can't be there in person. I saw some pictures from Dr. Cobb. It looks beautiful there. But I appreciate the invitation. And today I'm going to talk about some imaging endpoint strategies that we've been working on for both early and kind of later stage clinical trials before you kind of gear up for your phase 2. These are my financial disclosures. And so why is this really relevant? Well, we know that about 91% of phase 3 trials fail in glioblastoma, and the average cost for these trials are about $75,000 to $125,000 per patient. So these trials that involve hundreds of patients end up costing tens of millions of dollars to run. And many times these decisions to move into this phase 3 space are based on sort of soft endpoints, things like single arm studies looking at PFS6, which is the proportion of patients that, progress beyond 6 months. About 50% or more phase 3 trials are really based on this type of approach. And so a lot of what I've been working on recently is trying to de-risk these later stage trials, providing confidence that we have some kind of a biologic effect that can lead to some clinical benefit. And so one strategy we've been taking is in these early phase trials, so phase 0, window of opportunity trials, as well as dose escalation studies, really trying to nail down things like blood-brain barrier permeability, penetration of the drug, engaging the target, and then further downstream biologic effects that we know must happen in order for us to see any kind of clinical benefit. So as many of us know, the blood-brain barrier is really one of the biggest concerns for drug delivery and drug development in brain tumors. We do have breakdown to some degree of the blood-brain barrier in areas of contrast enhancement, and advanced imaging like dynamics contrast enhanced MRI, a perfusion technique, can give us a little bit of information about how leaky the blood-brain barrier is in those contrast enhancing areas of the tumor. However, that only tells us that the contrast leaks in that area. It doesn't tell us whether or not the drugs really penetrate and can stay there for long periods of time. So early on in drug development, we're really encouraging companies and investigators to try to radiolabel your drug to confirm penetration. This example here is from Elizabeth Gershner at MGH, just showing that we're able to radiolabel temozolomide, for example. And this particular study was looking at penetration of temozolomide before and after bevacizumab, which we think seals the blood-brain barrier. And you can clearly see penetration of temozolomide beyond just the areas of contrast enhancement. And she was able to confirm that, the administration of bevacizumab does change the permeability and the penetration of temozolomide, for example, and probably speaks to why it's less effective when given in combination. So again, this kind of shows that, again, what we think is really useful in glioblastoma, at least to some degree, does penetrate, does infiltrate non-enhancing tumor as well. Now, if we look at, these were some studies that were done later on to just show, body response to some of the checkpoint inhibitors, but we're able to radiolabel nivolumab, for example, using zirconium radiolabeled antibody fragments, and are able to show that in systemic tumors that really respond to checkpoint inhibition, we do see significant reduction in PD-1 expression and the size of the tumor. Concurrently, these studies have been able to show that we really don't see penetration of this antibody within the brain. So that you would think that that you would do this early on in drug development, and it would save us the embarrassment or the cost of doing these expensive phase 3 trials. So as you know, the Checkmate series of studies were performed and really did not confirm any survival benefit in these patients. And one thing that has been tossed around is whether or not, we're just not seeing penetration of the antibody. And this could have been de-risked early on. So again, an example of how we might use that information early on. Now, once you get, you confirm that your drug penetrates, the next thing that you really want to look for, again, early on in drug development is whether or not you're seeing any downstream biologic effects within the tumor. So this is one approach that we've been taking with immunotherapies. We've been working with this company, Imaginab, from Inglewood, California here, just down the road. And they have a radio-labeled mini-body or antibody fragment that has a zirconium label. And they've done a variety of studies with systemic tumors, just showing, again, distribution and utility in looking at immunotherapy response. In collaboration with Rob Prins, who I think spoke here earlier, as well as other investigators in neurosurgery and in radiology, we've been doing this immunopet in patients and doing image-guided biopsies to try to understand kind of specificity and things. So this is after a combination of IPI and Nivo, doing a biopsy of these areas that we think are hot and cold on immunopet, and then able to do spatial transcriptomics to look for and confirm that we do see some of these immune cells again after combination immunotherapy. Again, still kind of in its infancy in terms of its utility and sensitivity specificity, but this is an example of how we can early on maybe look at changes in this type of imaging contrast to see whether or not we see a biologic change within the tumor early on in drug development. Another example of this is looking at EGFR inhibition. So we've been developing with Tim Clossy and David Nathanson, developing brain-penetrant EGFR inhibitors for glioblastoma. We know from preclinical and cell work that EGFR inhibition results in disruption of glucose metabolism, specifically glycolysis. So we theorized that we could use FDG PET, used ubiquitously in body cancers in order to see an early pharmacodynamic effect. So we designed a phase 2 trial using a moderately penetrant EGFR inhibitor, osimertinib, and we're able to scan, did a double baseline PET scan, and then within 48 hours of receiving osimertinib, we were able to do another PET scan to look at early changes in glucose metabolism. We were able to confirm that we're able to alter tumor growth rate, so just looking at, again, alterations in just the tumor growth trajectory. And we were able to show that this change in growth rate was proportional to the change in FDG PET, again, suggesting that maybe this isn't the right agent, but this type of approach where we see an alteration in glucose uptake might give us insight into whether or not this have clinical benefit. Now, I don't want to get into the weeds, but we're starting to take that sort of approach and adding more sophistication. So we know that EGFR inhibition results in alterations in glycolysis specifically, not just broadly glucose metabolism. So we've designed a combination imaging biomarker where we use FDG PET in combination with a pH-sensitive MRI technique, as well as perfusion MRI, to really nail down on what areas of the tumor really are highly glycolytic. This is just it kind of pictorially how we add or kind of combine this information from various imaging modalities to get what we're calling a glycolytic index, how much glycolytic flux spatially within the tumor. In that same trial, we were able to show that we see a visual reduction in this glycolytic index, and then we're able to confirm that that's proportional to both progression-free and overall survival. Again, the difference in response that we see is maybe not clinically beneficial. So this drug may not reach that threshold to move on to further phase 3 studies, et cetera. But it was beneficial in sort of a proof of concept that this type of approach might be useful for drug development. Now, as we move into kind of this later phase, the phase 1b to the phase 2 studies, we're really looking for translating those biologic effects into some clinical activity, and really looking for at least sustained inhibition of macroscopic growth, some sort of signal that would indicate that this is worth moving to the next stage. Now, this tends to be this space that's really difficult for pharmaceutical companies and investigators, where there's really a limited number of patients. This is typically a single-arm evaluation. Therefore, there's a variety of prognostic factors that we really need to control in order to get a handle on whether or not any outcomes are really meaningful. So tumor size, for example, can dramatically alter the outcomes in these patients. How fast the tumors are growing prior to coming in the study, neurologic status, and all of these things kind of affect our ability to really interpret these limited number of studies. One thing that's kind of universally recognized as a bar that we could try to reach is objective response rate. So this is the proportion of patients with a substantial reduction in tumor size sustained over a minimum period of time. And this is recognized as a sufficient endpoint by the FDA in both accelerated and full approval. So trying to reach some sort of a response rate benchmark is one of the first things that you can do in sort of this phase 1b to 2 to try to get your drug into patients quicker. Now, it's a pretty high bar. I mean, we know we published this a few years ago now, looking at just historically, what's the response rates that we see in phase 2, phase 3 trials. And in general, we see a response rate of about between 3 and 6 or 3 and 8% in a variety of kind of condition typical agents. So those cytotoxic chemotherapies, biologic or targeted agents, and immunotherapies for the most part. Anti-angiogenic agents, as we know, alter blood-brain barrier permeability, and really they alter our ability to kind of see a response. Although after reevaluation of a variety of trials now, we see that really the response rates are much, much lower, probably more on the order of 15% as opposed to averaging around 30%. But if we pool all these trials and all the patients from the trials into a single kind of correlation plot looking at chemotherapies, biologic agents, and immunotherapies, so excluding anti-angiogenic agents, we do see a nice relationship between response rate and overall survival. So the larger the proportion of patients that have tumor shrinkage, the more likely you are to move that median overall survival in your later stage trials. And just for context, I put the recently approved or positive study rather of dabrafenib and trametinib here in BRAF mutant. So we see a really high response rate, and that corresponds with an increase in survival. This really supports our ability to use response rate as a surrogate. So we did some more analyses and to try to come up with some benchmarks for drug development in this stage. And so if we assume that we have a control response rate of 7.6%, which is really the average of CCNU and temozolomide, we need about 40 patients in that trial and a target response rate of above 25%. So really 10 out of 40 in order to demonstrate enough confidence and statistical significance. Now, if you have an even higher response rate, you need less patients, right? So it really has to do with that minimum effect size. So this sweet spot of about 40 and 25 response rate, clearly you can, if you have an even higher response rate of 40 or above, you can do it in less patients, right? So again, this provides guidance for drug development in those stages. Another thing that we can do is try to drill down on trying to understand growth rate inhibition. So maybe you can't shrink the tumor, maybe your agent just doesn't do that biologically, and you just want to stabilize tumor growth. That should be meaningful in terms of prolonging survival and things like that as well. And so one thing we've started to propose is looking at and mandating or requiring pre-treatment scans prior to study enrollment. So, in the current RANO criteria or really the previous RANO criteria prior to RANO 2.0, there really was this understanding that you have in the recurrent setting a measurable mass and that it was growing prior to, but no one was really measuring it or seeing how fast it was growing. But and we've learned from retrospectively looking at and collecting this information that anywhere between 20 and 30% of patients don't have growing tumor coming into these studies. And so by eliminating those or even quantifying the pretreatment tumor growth rate, we can look at alterations in on-study or on-treatment growth rate to look at translating this into trying to understand clinical benefit. Now, this was instrumental for the development of the IDH inhibitors, both ivosidenib and vorasidenib, where, in looking at just, RANO criteria, many of the patients had stable disease over a long period of time. And really the FDA was like, is this normal? Is this, it's not very informative as to whether or not the drug is working at all. And it wasn't until we started to look at individual patients and looking at their pre-treatment growth rates and then on-study growth rates that we were able to convince ourselves, the company, the FDA, et cetera, that, look, there seems to be a clinical effect. It does seem to shrink tumors over a long period of time, albeit, but it does seem to have some kind of a biologic effect. And then, we then moved into this phase 3 setting, also concurrently quantifying tumor growth rates, and we're able to show in the phase 3 setting that tumor growth rates were altered on study. Even after crossover, those patients that received vorasidenib at crossover had a reduction in their tumor growth rates, and this translated into a significant progression-free survival, which was the primary endpoint for the phase 3. So again, this level of evidence leading to us being able to evaluate this. And then just lastly, we can apply this to glioblastoma, not just in the low-grade setting, by layering on something like progression-free survival at 6 months, which is, again, typically used in those phase 2, but adding a little bit more granularity, saying that not only do you have to reach that benchmark, but you have to also slow the tumor down. And looking at single center data here, we're able to show that those patients actually have a survival advantage, in looking at patients treated with chemoradiation, radiation or chemotherapy alone. Anybody that has an alteration in growth rates and meets that criteria does have a survival advantage. We've implemented this now in a couple of different trials. This was in Adult Brain Tumor Consortium, 1801, looking at IDH mutants treated with temozolomide as well as a PARP inhibitor. So again, looking at the proportion of patients that had a tumor growth rate alteration gives us a little bit of insight into whether or not there's any biologic activity and whether or not it'll translate to those later stages. So in summary, I think in these early phase studies, we have this opportunity to really measure vascular permeability, drug penetration, characterize early biologic changes, maybe do dose-dependent changes in some of these imaging measurements as well. And then as we move into this kind of phase 1B, phase 2 setting, trying to look at whether or not response rate or growth rate alterations occur to try to provide more evidence that this might be successful in later stage trials, while also being mindful and trying to control for these prognostic factors like tumor size, neurologic status, and things like that. So the ultimate goal here is to provide insight into selection of new drugs that are really going to be worth our while kind of in those later stage environments. So thanks again for the invitation. Thanks to the funding and to all the members in the lab and my collaborators. So I appreciate it.
Thank you so much for your wonderful talk. That's very, very elucidating for imaging. Does anyone have any questions for Dr. Ellingson?
Yeah. Good morning, Dr. Ellingson. Zach Litvak here at the Ivy Center. I'm curious, in some of the retrospective looks you've taken at what the impact of doing some of this imaging up front would have been on trial design, have you estimated cost savings or wasted dollars, including patients that maybe should not have been included based on looking at what their imaging had been?
No, I haven't gotten into that sort of financial aspects of it. Now, it was enlightening to see how many patients, don't have actively growing tumors that are enrolled in these trials. And I get it, because clinicians have, they have a lot of conflicts, right? They have different biases. They want to give patients potentially life-saving drugs. Even if they're stable, that still makes sense. I think by characterizing, even if you have a shrinking tumor coming into a study, you still can use that information to determine whether or not you have a drug effect, right? Because if you're able to shrink it even faster, that might indicate that this combination of this drug, even if there's not washout from the previous treatment, maybe having a combination effect, and we can capture that as well. So, yeah, I don't have a good answer about the cost savings. I do know that it's surprisingly a lot of patients that have this kind of phenomena. The other thing that I didn't touch on is there in the design of these recurrent settings, there's a buffer between when you get that baseline MRI scan and when you typically get your first dose of drug, right? And that can be upwards of 14 to 21 days sometimes in some trials. We've shown that interval tumor growth between your baseline scan and the giving drug can be so quick that even if your drug does alter the growth rate, you may progress by that first scan and be taken off study. So we did a small study where we looked at getting kind of a hyperacute baseline on the morning before the patient got dosed with drug. And 3/4 of the patients would have progressed at that first time point, but they actually saw stability, at least temporarily, for a few months. So I think the way that we design these things has to be really carefully looked at to kind of squeeze out every bit of information. We may be missing a signal in some failed drugs in the past.